Thank you.
The president of Delhi Ophthalmic Society.
Thank you, Suma, for the introduction. Thank you, ma'am, for the opportunity to be here. And I'll be talking about optic neuritis. There are a few subtle differences in a child as compared to an adult, but the initial part of my talk will be generally trying to understand optic neuritis. And of course, the other spectrum that we are now beginning to see and hopefully try to understand. I do not have any conflict of interest. So the challenges are, particularly when it comes to a child, whether there is actual true visual loss or not, whether it is optic neuritis or not, then what is the potential etiology, which we can try and see whether it's typical or atypical, what are the key investigations to be done, and finally, what is the management options. So optic neuritis is inflammation of the optic nerve. Again, remember the definition when we are talking about. Now we move towards inflammation of the optic nerve. The typical clinical features in a normally defined typical optic neuritis would be in 20 to 50 years. So it's young adults who are affected. So the moment we talk about a child, we are in the realm of what has been described or clinically perceived as typical. So usually typical would be uniocular, would be in older patients, not the children that we are talking about, usually associated with painful loss of vision over hours. The pain is not severe, it's generally associated with eye movements. The vision loss can be subtle to complete. In a child, the challenge becomes one, assessing the actual vision loss, and also that the duration of vision loss, because children may not come to you with only single eye involvement. So many of them would miss one eye involvement, and therefore you are not sure what is the duration of the vision loss that the child may be having. Conventionally, typically the patient's vision loss would worsen to maximum about 2 to 3 months, a week, settle down, kind of level off and then start improving. The presence of an RAPD in a unilateral case, in fact, that's one of the major signs that you're picking up, particularly in a child where you're not able to pick up the visual acuity, and of course the fundus appearance. Now the atypicality comes obviously the moment we are looking at an age group which is outside what is conventionally described for typical. The vision loss is very sudden. There is either absolutely no pain or very severe pain. Older patients, bilateral involvement, so there is obviously an overlap or confusion if you're looking at ischemic or not. Severe disc edemas, disc hemorrhages, progression of vision loss which continues, or there is no treatment even on, no improvement even on treatment, and recurrent. Now recurrent optic neuritis is not so uncommon in a child, but essentially will still continue to be classified as atypical when you are describing or discussing optic neuritis. The importance of defining this, or the importance of separating these two into typical and atypical, is more now to do with the etiology than anything else. We know that most likely, again there are no rules, most likely a typical presentation may be demyelinating or idiopathic isolated. So that is one group you're looking at, and that's the concentration you're doing at. So the child you're looking at, it may be just isolated idiopathic, you treat and he probably will never come back to you again, or right at this moment we are seeing some signs or features of multiple sclerosis, and or they may develop over time with recurrence or as the child gets older. Atypical, on the other hand, has a completely different etiology. Now it does not mean that atypical presentation may not be seen in multiple sclerosis or even idiopathic, but the likelihood of it being because of many of the other causes is something that we need to look at. Most importantly, for a child, it can be post an infection or vaccination. So adequate number of cases have been reported after a vaccination also, and of course post infection. So they may have just a small URI, they may have just a small low grade fever, and they come to us with a vision loss. The diagnosis essentially remains clinical, and in a child we know that it can be challenging, particularly trying to accurately measure visual acuity, what to talk of looking at other visual functions like color, contrast and fields. But these are essential to be able to get a baseline and see how the patient is moving and trying to understand the clinical profile of the disease. In a child VER, again, you can aim to get a pattern VER, but sometimes you just have to make do with a flash. Flash is not that useful and doesn't convey as much, but in the absence of a child fixing for long on the pattern, you would have to do with that. And again, OCT is just more or less for understanding rather than truly diagnostic at the moment, although there are differences in MOG and optic neuritis, subtle features difference in OCT. The sea change or the major change that has come out in the recent few years, besides of course the blood markers that we'll talk about, is the role of MRI. Even earlier MRI was important and was considered helpful in understanding the progression to multiple sclerosis, but I would say now it's almost mandatory. In fact, mandatory unless of course you have major financial issues which limit. There is no role of a CT scan. If you're suspecting multiple sclerosis, it's as simple as to write an MS protocol, but essentially implying that it's an MRI brain in orbits with contrast, with fat suppression for the orbits and flare for the brain. Of course, the moment you write MS protocol, hopefully the radiologist will understand. Spine only if there are history of limb weaknesses or a suspicion that the patient may have NMO. The MRI features itself start giving us an idea as to what the etiology may be or what the cause may be. So MRI features are different. For multiple sclerosis, what we are classically taught with that there would be small segment involvement of the optic nerve that is affected, and sometimes of the other eye also. You may have the Dawson finger, so periventricular lesions that are there perpendicular to the ventricles. So these are classical features. But the moment you have atypicality in this, like long segment involvement, like you see in NMO going right up to the chiasma, or bilateral involvement of long segments anterior part of the optic nerve in MOG. So these are important differences, and at the very onset you start getting an idea that you may be dealing with a particular form. So as I mentioned, not only is the MRI changes different, the clinical presentation as we talked. So atypical presentations, MRI showing us a suggestion as to which side we are looking at, multiple sclerosis, NMO or MOG, and that is the way we can start moving on in these children, because as I mentioned, sometimes it's difficult to get detailed understanding of the visual presentations. Optic neuritis treatment trial gave us IVMP as the role model for interventions, and that remains the standard of care, at least definitely as our first line. You are suspecting optic neuritis, multiple sclerosis related. Your first line intervention was IV methylprednisolone with a short oral taper, and then you follow up the child. There is a role of disease-modifying agents in recurrent optic neuritis. In a child, you hope that it may be related to a mild inflammation or infection, and may let it go at that and follow up the patient to see for whether long-term disease-modifying agents are required or not. In an older patient, you need to actually discuss and be proactive, see the magnitude or the amount of MRI lesions that are there and the risk factors for future development of multiple sclerosis when you want to discuss the role of disease-modifying agents along with the neurologist. The NMO spectrum disorder is now something that we are increasingly understanding, especially now with the availability of the biomarker, and that has shown that there is a much higher prevalence of NMO in India and in Asia per se. In fact, in the early part of this century, when we were discussing optic neuritis in Asia and India, we would always say it is looking a little different from what ONTT has talked about. And possibly we were looking at a lot more NMO rather than a pure MS and optic neuritis. So a whole lot of different presentation is there for NMO, particularly presenting like atypical. Again, we are increasingly seeing NMO and MOG more likely in a child, but even NMO is now being seen. Acute attack of NMO, whether it's seropositive or not, is managed by high-dose methylprednisolone the way you would start. You're waiting for the blood sample report to come. If it is positive, you would continue your oral steroids for a much longer period of time. In fact, your IVMP may continue for 5 days or more. You will continue oral steroids for a long period of time, and if the vision doesn't recover, you may think of doing a plasma exchange therapy or a PLEX. So our interventions are different. Remember, disease-modifying agents are contraindicated in these patients. You may, after a long-term therapy of steroid, may have to switch with immunosuppressives like methotrexate in the long term rather than disease-modifying agents. It's important to early identify NMO and MOG because long-term prognosis does get affected by the delay in intervention. MOG is again another antibody that is being increasingly picked up, more common in children, more chances of recurrences in these patients. Fortunately, they do well by IV methylprednisolone in the first intervention that you have, but unfortunately, they keep getting recurrences, causing continuous and multiple attacks on the optic nerve, causing functional deterioration, and over long term, you may have a significant visual loss in these patients. So a patient of optic neuritis, typical, investigate, IV methylprednisolone, improves, follow-up. No significant improvement or deteriorates, or there is steroid dependence, it itself becomes an atypical feature. Revisit the child, and of course, long-term management will depend upon the clinical profile like MRI changes and the blood reports. We have an increasing treatment option. A lot of them fall in the realm of the neurologist, so your intervention has to be in association with the neurologist and discuss the long-term therapy based on the diagnosis that we have. And these children require a very, very long-term follow-up because they may develop these diseases over the long term. This is a very complicated kind of a map that we had made. This is published in IGO and is available open access. So this is just a broad overview, kind of repeating what I have said. It's important to get your diagnosis correct in the initial period so that you can intervene appropriately, more aggressively if you have NMO or MOG, and moderately so if you have you have optic neuritis due to MS. So identify biomarkers. Baseline MRI is now essential. Your clinical features may overlap between a lot of these, so you need to be careful, and investigations is now the key. And because they are different entities, their management is different, so be sure what your diagnosis is as you plan your management. Thank you very much for the opportunity.
Thank you, Rohit, for presentation. Any questions from the audience? I'm sure there'll be a lot of questions.
Ken, do you see patients with tuberculous optic neuritis in your practice?
So now that's a little difficult diagnosis to make. So two ways you're looking at it. Either you're looking at tuberculosis as the primary cause, so you're looking at lesions, or you're looking at infection, inflammation around the optic nerve related to a possible tubercular pathology. The other group is that tuberculosis is there in the patient, and I'm not very sure whether it may not be directly infective, but we believe it may be because of some of the toxins that are being produced. I would say we do not see any significant number of patients who are directly due to tuberculosis, but unfortunately we see a lot of patients related to the interventions that we're giving, particularly thiambutal. So currently I would say if I have a patient with a perioptic nerve head lesion, a choroidal lesion, I would suspect tuberculosis because that is maybe a tubercular lesion, which is a juxtapapillary lesion. So that is a possible presentation of tubercular optic neuritis. But as a lesion elsewhere and remotely causing optic neuritis, I don't think there is enough evidence for us to be able to correlate that closely.
In adults, we do see TB optic neuritis. They present, as you said, with the disc granuloma, which later on heals with a peripapillary scarring.
Absolutely.
And there you will find even tuberculous lesions, like small choroidal lesions elsewhere in the fundus,
Right.
which heal with scarring along the vessel. So
Absolutely, yeah. That is a group that one would see. And as you said, I mean, you see a lesion that is not typically looking like the disc edema that you would see. It's a fuller edema. You'll see some choroidal changes, juxtapapillary, and that sets you off thinking that it may be infective.
Okay. Thank you, sir.
Madhvi had a question.
Rohit, you said that we generally do not use monoclonal antibodies in these type of cases. But there have been some studies on the use of rituximab in to prevent the relapse or recurring cases of NMISD. And the results have been somewhat promising in the initial stage. I do not know what the third clinical trial final results are there, but that have been used and has been recommended. Am I right, Rohit?
So there is very good evidence for adults. Rituximab has been used for preventing relapses in adults. For children, it's still not clearly established. So as I mentioned, at least in the Indian setting, a lot of these children may not come back with relapses or have such a long term. But yes, the moment you have a serum positive patient, your interventions change. if you have a seronegative for NMO and MOG and you think it's just a demyelinating lesion, you may in a child still be willing to follow up. But yes, the adult management is different, and that's why I didn't stress so much on the long-term management with immunosuppressives and immunomodulators.
Hello, sir. Thank you for the presentation. So, my name is Dr. Madhvi. So, I'm currently working at Sitapur Eye Hospital. We encountered a patient, a child with a 7-year-old child who had no previous history of any infection with bilateral vision of vision loss of till 6/60 in 2 weeks, and on MRI there was perineural enhancement. So in these patients, the child was not, the parents were not able to afford the serological investigation, any investigations. So we started with we gave the child steroid, the disease regressed, and when we tapered the steroid and stopped, it again recurred. And we had to again start a short course of steroid and taper it very slowly. So in such patient, how do we proceed when the patients are not able to go for serological investigations and they are presenting for a very poor socio-economic status, sir?
As you mentioned, the MRI was suggestive. So if you don't have, that's why the stress now on MRI. So MOG would tend to present with a long thickening of the nerve with particularly perineural sheath enhancement. So if you see that, that is fairly suggestive of a MOG, and you would then increase your steroid course and have a very slow taper, because in these patients, you are going to see recurrences, and possibly, again, we don't know in hindsight, some of those patients we used to label as cryon were probably those who were MOG. So that is why we know that they are kind of steroid sensitive, but also steroid dependent. So your therapy may be long-term steroid, and if it again recurs after you stop or taper steroid, you may have to think in terms of shifting the patient onto an immunosuppressive treatment as a long-term measure.
Thank you, sir.